Welcome to the deep dive. Today we are looking at something that honestly might keep some of you up at night.
Oh, absolutely. It is a massive shift.
Yeah. So we are unpacking the FDA's February 2026 cybersecurity guidance. And we are specifically tailoring this for you, the quality assurance and regulatory affairs professionals who are, actually in the trenches trying to get these medical devices cleared.
Right, because the stakes for QA and RA teams right now are just incredibly high. I mean, the margin for error is gone.
Completely gone. Because if an FDA reviewer spots a cybersecurity deficiency and they issue an AI letter, an additional information letter, that one letter can add, 8 to 12 weeks to your timeline?
Easily, yeah, 8 to 12 weeks of delay, which
Yeah.
means lost revenue and, patients waiting longer for the care they need. So getting it right the first time is really the only way to ensure a smooth launch.
Exactly. So to give you that smooth path today, we are pulling together intelligence from a bunch of top sources. We've got the
Yeah.
official FDA guidance, obviously,
Right.
but we're also synthesizing on-the-ground analyses from groups like Blue Goat Cyber. And they've cleared over 250 submissions with zero cyber rejections, so they really know their stuff.
Yeah, that track record is pretty wild.
It is. We also pulled insights from Hattrick IT, Sensinet, L4B Software, Apotec Consulting, and RAPS. The mission here is just to cut through all the dense regulatory jargon and give you the practical, real-world mechanics of what the FDA actually wants to see on their desks.
Exactly. We are taking all that theoretical compliance and translating it into concrete engineering artifacts.
So let's just jump right into the timeline here. The FDA updated this guidance in February 2026, which was surprisingly fast after the 2025 version. Did they just completely rewrite all the technical rules on us again?
Well, no, the actual technical rules, so the testing requirements, the cryptographic standards, those mostly stayed the same.
Okay, thank goodness.
Yeah, but what happened in February 2026 was this massive administrative shift. I mean, it fundamentally alters how device companies operate. The FDA replaced the old QSR, the quality system regulation under 21 CFR 820, with the brand new QMSR.
Quality Management System Regulation, which on the surface just sounds like a government agency swapping one acronym for another.
I know, it sounds minor, but the practical implications are huge. The new QMSR officially incorporates ISO 13485.2016 by reference.
Right.
So for global harmonization, that's great, but for cybersecurity, it completely destroys the old way of doing things. Historically, cyber was this separate IT exercise. It was just managed by software engineers in a silo.
Yeah, way over in the corner.
Exactly. But under the QMSR, cybersecurity is now a legally mandated, explicit part of your quality management system.
It's kind of like, I was thinking about it like this. It used to be like wearing a hazmat suit versus, engineering a device with its own internal immune system.
Oh, that's a great way to put it.
Right. Because a hazmat suit is just bolted on at the end to protect you from the environment, but it can tear. And now the FDA is saying you can't just wrap a medical device in firewalls after the fact. That immune system has to be drawn right into the original architectural blueprints under the QMS.
Yeah, exactly. And to put that into the daily language of a QA professional, it means your security controls must be formal design inputs and outputs.
Right.
When you build your ISO 14971 safety risk management file, that master document where you calculate patient harm cyber risks have to be mapped explicitly inside that exact same file.
Oh, wow. So if a reviewer sees that you handled security in a separate risk register from patient safety, what happens?
Your submission stalls. Full stop. A software crash that's caused by a hacker has to be traced directly to the biological harm it causes the patient.
That is a huge mindset shift.
Yeah.
And while QMSR is the framework, the actual law giving the FDA the teeth to reject you is Section 524B of the FD&C Act, right?
Yes, Section 524B. And that applies to any quote-unquote cyber device.
Okay, so I want to push back on this a bit because I know teams dealing with legacy devices struggle with this.
Yeah.
I totally get that a device with active Wi-Fi streaming to the cloud is a cyber device.
Sure.
But what if I have a device with a dormant debug port? Like, the engineers left a tiny physical port on the circuit board for factory testing, but it is covered by a hard plastic casing.
Right, the classic hidden port.
Yeah. The doctor can't even reach it. So how can the FDA demand a massive cyber review for a port that doesn't even connect to the internet and is physically walled off?
Well, because physical plastic casings do not stop insider threats or, supply chain attacks.
Oh, interesting.
Yeah, the FDA assumes a bad actor doesn't have to be some hacker in a basement halfway across the world. It could just be a compromised technician at a maintenance facility.
Right, someone who actually opens the casing.
Exactly. They open it during routine servicing and just plug a flash drive into that debug port. Or maybe there's a dormant Bluetooth module that you plan to turn on in a future software update. If the physical hardware can interface with the outside world, the FDA assumes a highly motivated attacker will eventually reach it.
So because of that, QA teams really have to change how they do their math. For decades, quality engineers have relied on actuarial data. You test a physical part, like a plastic gear, and you calculate the exact probability of it failing after 10,000 uses.
Right, you can calculate physical wear and tear, but software vulnerabilities don't wear out. And hackers don't care about actuarial tables.
Exactly.
A vulnerability could sit undiscovered in your device for 5 years, and the risk seems like it's 0%. But then tomorrow, some researcher posts a script on a public forum showing how to exploit it.
And instantly the risk is 100% across the globe.
Yes. Because anyone with a laptop can execute the attack millions of times a second. So the FDA forced a change. You can't calculate the quote-unquote probability of an attack anymore. You have to assess the exploitability of the vulnerability.
You basically have to assume the threat is already at your front door.
Precisely. You assume they are actively targeting you.
Okay, so if we can't use our standard probability math, how do we actually prove this exploitability and prove the device is safe to the SDA? I know we have to use an SPDF. But what is that, really? Is it just more paperwork?
No, the SPDF, the Secure Product Development Framework, it is not just a form or a checklist. It is an end-to-end engineering discipline.
Okay.
And it starts with threat modeling. You have to systematically identify every single way someone could attack the device, and the FDA expects to see that you used a structured tool for this, like STRIDE.
Let's unpack STRIDE for a second so we aren't just throwing acronyms at you. What does STRIDE actually force the engineers to do?
So STRIDE stands for spoofing, tampering, repudiation, information disclosure, denial of service, and elevation of privilege.
That is a mouthful.
It is. But instead of just sitting around a whiteboard guessing what a hacker might do, STRIDE forces the team to look at every single data pathway and ask specific questions. Can someone spoof an identity here? Can they tamper with the data while it's moving?
Can they elevate their privileges and become an admin?
Exactly. It builds a really comprehensive, structured map of your vulnerabilities.
And here is where Blue Coat Cyber had a really practical insight. After clearing hundreds of these packages, they said the number one reason a submission fails isn't a missing document. It's a broken thread in the traceability matrix.
Yes, that is such a common trap.
Let's walk through that. Say we use STRIDE when we find a threat. A hacker could spoof a firmware update to take over an infusion pump.
Okay, so that's your threat. Now the reviewer looks for the control. How did you design the pump to stop the spoofing?
Right. So the engineering team implements cryptographic signing. The pump will only accept an update if it's digitally signed by the company's private key.
Perfect. But here is where the thread breaks. The reviewer sees the threat, they see the control, but then they look for the specific testing evidence. They want to see the actual log of a test where you purposely tried to force a malicious, unsigned update through and the pump rejected it. If you have the threat and the control, but no testing evidence, the thread is broken. You fail.
Wow. And this traceability issue brings up a really critical nuance about responsibility, especially with third-party software. Yeah. Like, say you're building a device and you use a regulatory-grade operating system, like Medi2UX, to run the display.
Right.
That OS vendor can give you a nice binder of evidence showing their secure boot controls, right? Yeah. But you can't just hand that binder to the FDA and say, well, Medi2X handled it.
No, you absolutely cannot, because you are the OEM, the original equipment manufacturer. You own the device-level submission.
The buck stops with you.
Exactly. You have to weave their evidence into your own SPDF, your own validation, and your QMS. The FDA is evaluating the entire finished device, not just the OS it runs on.
Okay, so you've got your SPDF, you've mapped the threats, your code is locked down. But modern devices use tons of outside ingredients, third-party libraries, open-source drivers. How does the FDA know those aren't compromised?
That brings us to the SBOM, the Software Bill of Materials.
And people always think this is just an Excel spreadsheet, right? Like a manual list of ingredients.
Yeah, and that is a very costly misconception. A static Excel spreadsheet will get you rejected. The FDA requires a machine-readable, living document.
Right.
It usually needs to be in a highly structured format, like SPDX or CycloneDX.
So why do those formats matter so much? Like, why can't I just save my Excel sheet as a CSV file and call it a day?
Because a CSV is just flat text. Formats like CycloneDX are relational metadata structures. They don't just list the ingredients, they map the complex relationships between them.
Okay, give me an example of that.
So if your software uses ingredient A, and ingredient A secretly relies on ingredient B, and B relies on C, that is a transitive dependency. A machine-readable format maps that entire chain. So if a flaw is found in ingredient C, an automated tool can instantly flag your device as vulnerable. A human reviewer looking at a flat CSV could never trace that fast enough.
That makes total sense. And that's why the FDA relies on the NTIA baseline for the SBOM elements.
Yep.
You need the supplier name, component name, unique identifiers, author, timestamp, and the exact version number.
Yes, the version number is critical.
Apotec Consulting pointed out that missing just one of these elements, like forgetting to pin the exact version of an open source library, is an automatic technical screening hold.
Because without that exact version number, nobody can monitor the National Vulnerability Database to see if a new flaw actually applies to your device. It is the linchpin of post-market surveillance.
Which honestly leads to a huge headache for QA teams. Say your machine-readable SBOM scans the database and finds a terrifying critical vulnerability in some obscure third-party library. But your engineers look at it and realize, wait, that library is only used for a wireless printing feature? And our device doesn't even have wireless printing enabled. So you have this huge risk on paper, but zero actual risk to the patient.
Exactly.
How do you tell the FDA that without having to rip your software apart to fix a non-issue?
That is exactly what the VEX document is for. The Vulnerability Exploitability Exchange. It is a communication tool to provide context.
It's like having a giant may contain peanuts warning on a food factory. The database sees peanuts and freaks out.
Right.
But you use the VEX document to say, yes, we have peanuts in the building,
Yeah.
but we built a totally sealed, biologically isolated room for this specific product, so nobody's getting an allergic reaction.
That is a perfect analogy. The VEX lets you officially tell the FDA, yes, this component has a known vulnerability. But because of our system architecture, because we disabled that port, it is not exploitable in our device.
It just saves thousands of hours of unnecessary engineering work.
Yes.
You mentioned architecture, which is another huge area. You can't just write down your security narrative in the SPDF. You literally have to draw them a picture.
Yes. The FDA explicitly requires 4 specific visual architecture views.
Right.
First is the global system view. That maps how your device fits into the broader hospital network and the cloud. Second is the multi-patient harm view.
That view sounds uniquely chilling. Multi-patient harm.
It is. QA teams usually assess how one broken device hurts one patient. But this view forces you to map out how a hacker could breach a single smart infusion pump, use it as a beachhead, scan the hospital network, find 50 other pumps, and alter all their dosages at once.
Oh, wow.
Yeah. The FDA demands to see the architectural firewalls you built to stop that kind of lateral movement.
Unbelievable. And the third is the updatability and patchability view, which diagrams how you safely push updates. The fourth is the security use case view. But drawing the maps isn't enough, is it? You have to try and break them.
Exactly. A standard automated scan won't cut it anymore. The FDA expects rigorous, context-aware testing. They want static and dynamic code analysis.
So for anyone outside the software engineering silo, static analysis is basically proofreading the recipe before you cook. Automated tools scan the raw code looking for obvious mistakes, like a hard-coded password.
Right.
And dynamic analysis is tasting the soup while it's boiling. The tools watch the compiled software while it's actively running to see if the memory crashes under pressure.
That's right. And on top of that, you need fuzz testing. This is where you throw massive amounts of random garbage data at the USB ports, the Bluetooth, the APIs, just to see if the system gracefully rejects it or if it panics and opens a back door.
And then independent penetration testing. But you can't just hire a generic IT firm. Your pen testers have to understand medical clinical workflows. If they hack a heart monitor, they have to document exactly how that compromises patient safety.
Yes, context is everything.
Okay, so you do all this. You submit the SPDF, the machine-readable SBOM, the VEX, the architecture views, the testing logs. You survive the review. The device hits the market. Pop the champagne. But are we actually done?
Not even close. The post-market phase is where the real pressure test happens. The FDA requires a mandatory cybersecurity management plan, and a core pillar of that is your Coordinated Vulnerability Disclosure Process, the CVD.
That's essentially an if you see something, say something protocol, right? You need a public, secure channel for a hospital IT admin or a white hat hacker to report a vulnerability without fear of getting sued.
Exactly. But receiving the report is just step one. Section 524B makes your post-market patching commitments legally binding. You aren't just promising to try your best. You are legally required to fix unacceptable risks.
And the timelines are aggressive. Let's talk about the realities of deploying a patch to a live hospital environment.
The FDA leans on industry best practices here. If a critical vulnerability poses an uncontrolled risk to patient safety, you generally have 30 days to investigate it, engineer a fix, and create a mitigation strategy.
Okay, 30 days.
And then you have 60 days to actually deploy that patch to the physical devices operating out in the field.
Wait, 60 days to push a patch across multiple hospital networks? If you didn't nail that updatability and patchability view on day one, you will never hit that deadline. Your system will just be too fragile.
Exactly. And failing to meet these post-market patching rules is a prohibited act under Section 301Q of the FD&C Act. It turns a software delay into an active, severe legal liability for the manufacturer.
Wow. Let's bring this all home for you listening. The core takeaway from diving into the FEV 2026 guidance, the QMSR transition, and Section 524B is this. Security is no longer optional. It is clinical.
Absolutely.
The FDA isn't just adding an IT checklist. They are permanently fusing cybersecurity into the DNA of your QMS. If there is a broken thread between a hacker spoofing an update and the test proving you stopped it, your clearance stalls.
Maintaining visibility with a machine-readable SBOM and proving you can withstand multi-patient attacks is the absolute cost of entry now.
I want to leave you with one final thought to mull over today. As medical devices get more deeply integrated into cloud AI and massive hospital networks, the line between a software bug and a biological hazard is just completely gone.
It really is.
The FDA says cybersecurity is part of safety and effectiveness. So knowing that, how will QA and RA teams fundamentally evolve their hiring and their culture over the next 5 years? We are rapidly approaching a world where a quality team must treat a single vulnerable line of code with the exact same reverence and strictness as they treat the physical sharpness of a surgical scalpel.
The digital and the physical are one and the same now.
Yeah.
To protect the body, you have to protect the code.
We started by talking about X-rays and broken bones, things we can physically see. The digital landscape might seem invisible, but with frameworks like the SPDF and machine-readable SBOMs, we've basically built a new kind of X-ray machine for software. It lets us see the dangerous fractures in our code before they ever reach a patient. Thank you for joining us on this deep dive. Take these insights back to your teams, review your QMS procedures, and until next time, keep learning and keep building safe systems.